Hello, coders! So today we're going to go through female genital surgery and maternity care. So just like all of our other surgery sections, the three easiest ways to search for these procedures are going to be either the name of the surgical procedure itself, like a hysterectomy, the name of the anatomic site, such as the vulva, or the name of the condition, such as pregnancy. Now, what you'll notice is the way that they deal with the female genital system is a little different than the male genital system. So we're going to start from the outside on the vulva, which is everything external. That will include the vulva itself, which is the clitoris, the labia minora, the labia majora, and all of the skin on the outside. We then move up into the vagina. Then in the cervix uteri, remember cervix uteri is the cervix. Then we get into the corpus uteri, which is the actual uterus itself. Then our codes go into the oviduct and ovaries. So we're dealing with the fallopian tubes, which are also known as the oviducts, and then the ovaries themselves. Then at the end of female genital, we get to our in vitro fertilization, and then we start our maternity care. So we're going to see all the different parts of the female body as main terms. We're also going to be able to look up things like in vitro fertilization and also the different parts of the procedures, like a colpotomy versus a colposcopy. We're going to have laparoscopic surgery in this section. Again, we can look up pregnancy as a main term, also the type of delivery as a main term, and we do have codes for abortion here as well. So we start by looking at page 371 in our code book. The first thing that you're going to notice is that they have these 4 definitions. And these are specifically for our vulvectomy codes, which are directly to the right. You can see my little pink highlights are showing up over here. So these are going to be more for really infectious diseases and also for things like cancer. So when we're talking about the removal of part of the vulva, simple is removal of skin and superficial subcutaneous tissue. Radical is removal of skin and deep subcutaneous tissue. Now this is where it's really important to know your definitions, and that's why these are here. Partial is considered less than 80% of the vulvar area. Complete is greater than 80% of the vulvar area. So this again is why they have these definitions in here, because in other areas of the book, partial might be considered 60% or less, versus here it's 80%. And so if we're dealing with vulvectomies, again, are we dealing with the simple, radical, partial, complete, and also we're going to see some radical procedures here, because again, if this is invasive cancer on the vulva, then we might have to do things like remove surrounding tissues and lymph nodes. Otherwise than that, we're going to see things like our incisions. So right here, we have to be careful. The Bartholin's glands are the glands on either side directly inside of the vagina. But you'll see the notation here for incision and drainage of a Skene's gland abscess or cyst. Use 53060 because the Skene's glands sit right inside of the urethra. So we need to be careful. Again, a lot of times because they're so close together in the female genital system, people confuse the Skene's and the Bartholin gland. They are in separate sections because one is considered inside the urinary and one side is considered inside the female genital. We're also going to see things like this one, marsupialization of a Bartholin's gland cyst. And it's what you think it is. Remember, marsupials, things like koalas and kangaroos, have pouches. That's what makes them marsupials versus normal mammals. And so what marsupialization means is to create a pouch. And for a Bartholin's gland cyst, what they do is they kind of create a pouch so the cyst can't recreate. So they remove all the cyst and create this little pouch so the cyst doesn't come back. Then we're also going to see, again, all of our excision codes for the vulvectomies. We're going to start seeing our repair codes as well. And then we get to the vagina. Now, what we have to remember is colpo that we see right here for code 57000. Colpo means vagina. It's one of those terms that we only really see when we're dealing with the procedure side of the female genital system. So a colpotomy, we're making an incision into the vagina. A colpocentesis, we're putting a surgical puncture to remove fluid. But we need to be careful because these codes are all Either obstetrical or non-obstetrical. So we have to be careful. So 57022 is incision drainage of a vaginal hematoma, obstetrical / postpartum, versus 57023 is non-obstetrical. So we need to know whether the woman is pregnant when we're doing a lot of these procedures. We need to clarify that information. That's why that's one of the first pieces of information that the provider is going to grab from the woman, especially if there's something dealing with her genital system for that visit, because we want to know as much as possible to know exactly what we're looking at. Are we looking at a pregnancy complication? Are we looking at a genital complication? Again, we're going to see some destruction as well. We have simple and extensive destruction for vaginal lesions. Again, these could be for things like HPV, for genital warts. It also could be used for other lesions that end up inside of the vagina. Again, we can do biopsies. So again, we're going to see these simple and extensive or simple and complete. And so again, be careful. How is the provider describing this? Are they describing that it's much more extensive than they thought? In this case, it's not only extensive for 57105, it also requires sutures. So again, that's one of the other big differences. Versus a regular biopsy of the vaginal mucosa, we shouldn't have to do any sutures. We're also going to see things like removal of the vagina as well. Again, that's really only done for very specific procedures, usually, again, extensive accidents or injuries. Again, one of the biggest issues with the female genital system is when it comes to STDs and STIs, especially the STIs like gonorrhea and chlamydia. Well, a lot of women don't know for sometimes up to weeks that it's in their system because it's completely internal. And again, that can create other problems. Otherwise, we also have to remember that although cervical cancer is more known to be in situ, localized, meaning it doesn't tend to spread to the rest of the female genital system, it certainly can spread down to the vagina as well. So again, we're going to see, the other thing I want to talk about, although I don't have a picture here, is the introduction on page 373. So remember, when we're talking about introduction in CPT, we're introducing something to the body. And in this case, we're introducing things like a diaphragm or cervical cap, brachytherapy, medication for treatment of a disease. So again, we're introducing something specifically to the vagina. So we want to kind of keep that in mind. When we see that word introduction, we're introducing something to that body system. In this case, because it's underneath the vagina subcategory, it's going to be introduced into the vagina. Now, when we get to the cervix uteri, we have to be careful because we have colposcopies of the vagina and colposcopies of the cervix. So again, this is very similar to when we were talking about the urinary system. Because when we talk about doing a cystourethropy, we need to get to the urinary bladder through the urethra. Okay, so this is very similar. We have to get to the cervix through the vagina. That is the most common way. Otherwise, we're slicing and dicing, but these are scope procedures. Remember, we normally scope into a natural orifice, which in this case is the vagina, or into an incision in a body cavity. So again, we have to be careful. Are we doing a colposcopy of the vagina or a colposcopy of the cervix? And again, the colposcopy of the cervix includes upper and the adjacent vagina, meaning the upper part of the vagina and the adjacent part, the part of the vagina that's right next to the top of the cervix. Again, we're also going to see some repairs here. Again, be careful. Things like 57700, claricage of the uterine cervix, non-obstetrical. Claricages tend to be done to help hold a pregnancy in because the cervix itself becomes what we call incompetent. But this can also happen to women as they age. One of the things that happens especially for those of you who want to become professional coders, is a lot of times you will go to continuing education meetings. I went to one last year and we had an OB/GYN. He really talked more about the GYN side after the OB, meaning women who have had multiple kids, now they're older. And he was talking about different prolapses and different issues with the uterus and the cervix that come because of multiple children. And so the clairclage can also be used to help with a prolapse of the cervix into the vagina. So the more children a woman has, the more likely, not that she's going to, but the more likely event that she may have a prolapse in the future. So this is the uterus, which remember is kind of like an upside down pear collapsing into itself, or in this case, this would be more the cervix collapsing into the vagina. And this is to give it extra strength. Then again, we get to the corpus uteri. Remember, endometrial. Here's the big thing. Keep in mind, we have 3 layers to the actual uterus. So again, remember, metrio. Okay, this is part of the uterus. Endometrial, this is the actual cells directly inside the uterus that we can access going through the vagina into the uterus. Okay, but again, we can go deeper into those tissues as well. Again, things like myomectomies, again. So this is going into the larger muscle area of the uterus itself. And again, in this case, we're doing an excision of fibroid tumors. So remember, keep in mind, neoplasms. Neoplasm, new growth. That doesn't mean it's cancerous. Fibroids tend to be non-cancerous, but they become very painful to most women. They also can produce a lot of bleeding and breakthrough bleeding in between menses and things like that. So for these, they're based off of exactly how much basically do they weigh and the approach. How did we remove it from the body? So just like we were talking about in the urinary system and the male genital system, if we can go in through a natural orifice to do a procedure, that's the way we try to do it. However, sometimes we're going to have to cut into the body to get to that area. So as we can see here under the hysterectomy procedures, we have abdominal hysterectomies, and you can see we have some vaginal hysterectomies. We also are going to have laparoscopic hysterectomies too. So again, we need to know, are they using a scope or not? And then whether they're using a scope or not, what's the approach? Are they going in through the abdomen? Or are they going in through the vagina? Because both for the regular hysterectomy procedures and the scope hysterectomy procedures, those are our choices. Abdomen, vagina, whether it's open or laparoscopic. The other thing that you'll know here is for the hysterectomies, are we just removing the uterus? Are we removing the uterus and the cervix, or removing the uterus, the cervix, and the fallopian tubes and ovaries? How much are we removing? Now, for some of you, if you go back and you ask your great aunts and great aunts, your grandmothers, and things like that, a lot of these women had these hysterectomies done because for years it was assumed that if you just take out everything, there's no more problems. We now understand more about hormones and how the ovaries themselves continue to create the hormones that we need in the female body. So nowadays, they will only remove the ovaries if they absolutely need to. Even if they only can keep in one ovary, it will still make enough of the secretions that we need to keep the female body going. So there's going to be a lot of women that you might see history of a hysterectomy, and it's been 30, 40, 50 years. And that was very traditional back then. Now it's an as needed procedure. We only remove what we need to remove. And again, here is the laparoscopic hysterectomy. And again, you can see here, the biggest thing is, again, size. So how large? And again, because you can have fibroids, you can have other types of tumors and lesions that can physically make the uterus larger and heavier. And so again, they do get paid a little bit more if it's heavier, if it's over 250 grams, and whether or not they remove the tubes and or the ovaries. So this is why if you've watched, different medical shows, on occasion, although they don't show it nearly as much as they used to on the shows, they would show a doctor. Usually it's like a medical examiner doing an autopsy, weighing somebody's heart. But when we remove these larger organs from the body, we do weigh them. And it's important because, again, when it gets sent to pathology, that could indicate something to the pathologist as well. So again, we need to be careful. How is this being described? And if information is not fully recognizable, query the physician. Always go back and ask the provider, I need more information. Now again, the oviduct ovary. So remember, the fallopian tube is also known as the oviduct. And again, what are we doing? So we can do, again, a ligation or transection. So right here in these incision codes, these are for sterilization. Okay, so we have a ligation or transection of fallopian tubes, abdominal or vaginal approach. Again, we can do unilateral or bilateral, so no modifier 50 here. Again, we can also do right here, ligation or transection of fallopian tubes, abdominal or vaginal approach, postpartum, unilateral or bilateral, during same hospitalization. Okay, so we're going to be getting to maternity care in just a few minutes, but before we get there, this is important to know. So a lot of women, when they go in to have their baby, they have already discussed with their OBGYN whether or not they would like to be sterilized. For most women who want to be sterilized, usually there are two main choices. Usually the doctor will say, well, listen, if we end up doing a C-section, we will do the ligation and sterilization right after you give birth to your baby. But if you have the baby naturally, then we will have to schedule it. Now, again, sometimes they schedule it during the postpartum hospitalization, and sometimes they make you wait. It really depends on what's going on with the woman. So we need to be careful because this is just scheduling it, just in general, this is scheduling it during the same hospitalization as delivery. But be careful, 58611, ligation or transection of fallopian tubes when done at the time of cesarean delivery or intra-abdominal surgery. So this is when done after mom has had the baby, but before she leaves the hospital. 58611 is being done at the same time, so right after they do the cesarean delivery, but it also can be used for any other intra-abdominal surgery. So for instance, if let's say they are going to be removing a fibroid from someone's uterus, and while they're doing that, they're also going to do a transection of the fallopian tubes, we would add on 58611. But we need to be careful again because this is at the same time, when done at the same time. Now, if a woman has to come back 6-8 weeks after she has the baby, 2-3 months perhaps after she has the baby, then we need to know how are we doing it. Because we have the transection ligation over here, or we have the occlusion of the flow rings by a device like a band or a clip. So these procedures up here, these go for all the different types of procedures that involve cutting, tying, cutting, burning, cutting, sealing, cutting, suturing. Okay, it's when we're cutting and then doing something else. The occlusion of the fallopian tubes by device is a device that goes on the outside of the actual fallopian tubes. Now, here's the thing. The occlusion of the fallopian tubes and the normal ligation or transection of the fallopian tubes can be reversible. It's not always a successful reversal, but it can be reversed. However, there is another procedure that also will fit under 58600, 605, or 611, depending on circumstances, and it's called the E-Shore. And what the E-Shore is it is a little device that is actually placed inside of the actual fallopian tubes. And this device itself, the idea is within a few months after the device is placed by a physician, that the skin of the fallopian tube grows over the device, and therefore it completely ligates and shuts off the fallopian tube connection. So the egg cannot make it into the uterus. So again, that does not fall under 58615 because that is not a band, a clip, or a ring. This is something that we actually place inside the fallopian tubes. And it has been around for a good 15, 20 years. And this is another procedure, though, that we do under moderate sedation, not under general anesthesia. Because, again, they can go through the vagina, into the cervix, up the uterus, and then place them into the fallopian tubes within about a half hour. Again, here's our laparoscopic procedures, again, with removal of different structures. And then the last section that we're going to see, which ends up on page 380, is the in vitro fertilization, which I do not have a picture of. The in vitro fertilization includes the follicular puncture for the oocyte retrieval. Okay, so that is after the woman has basically spent usually a couple of months pumping herself full of hormones. They will actually go in and they will remove some of her follicles, some of her eggs from her ovary. There's the embryo transfer intrauterine. And then there is the gamete zygote embryo interfallopian transfer. So that's going to depend on if the woman has had this procedure done before, if she has, what was successful about it, and what the provider would like to do. So usually what they do is, again, they're going to let the egg and sperm come together in a petri dish. And then depending on what the provider would like to do, sometimes they'll wait a couple of hours. Sometimes they'll wait up to a day or two before they transplant and do the transfer into mom. And so again, how is the doctor describing the procedures? Okay. So again, maternity care is completely separate from all of the other female genitals. So we need to know whether or not the woman is pregnant when we're dealing with these procedures. The big thing is either look up the exact name of the procedure or the anatomic site to find what you're looking for. Now, starting on page 381 is our maternity care and delivery. So the first thing it's going to tell us is what is included, and then I'm going to show you guys what we mean by these global codes. So normally there are a set of what we call global codes. That is when the woman sees the same OBGYN or midwife basically from start to finish, or someone in the same practice. So for instance, sometimes a woman goes to see a midwife, the midwife does an assessment and says, you know what, your case is a little complicated, I'd like you to see an OBGYN. As long as they're in the same practice, this all still counts. So the services normally provided in uncomplicated maternity cases include antepartum care, delivery, and postpartum care. So the visits beforehand, the labor and delivery, and the postpartum care. Now, pregnancy confirmation during a problem-oriented or preventative visit is not considered part of antepartum care and should be reported using the appropriate E&M service code. So for instance, a lot of women end up going to their primary care or their OBGYN for the urine pregnancy test. Okay, for pregnancy confirmation during a visit, that is not included in these codes. Okay, so basically after confirmation happens, that's when the antepartum care starts. The first visit you have with OBGYN after you've had the pregnancy confirmation. So antepartum care includes the initial prenatal history and physical examination. So that's when they go through your history, your family's history, and everything they need to know. Subsequent prenatal history and physical examinations, and again, all those follow-ups. Recording of weight, blood pressures, fetal heart tones, routine chemical urinalysis, and monthly visits up to 28 weeks gestation. So from when mom finds out when she's pregnant, she can go once a month, and this is all included. Then once mom hits 29 weeks, she usually goes bi-weekly every other week up to 36 weeks gestation and weekly visits until delivery. Now, this is what's important. Any other visits or services within this time period should be coded separately. So for instance, if a woman is high risk, and let's say for the last 6 weeks of her pregnancy, they want her to come in twice a week for non-stress tests. Those are coded separately and they are not included in these visits. If mom has to have extra ultrasounds, extra visits for this, extra visits for that, visits that are not directly related to the pregnancy. So for instance, if you have a woman who gets migraines and she's on migraine medication, she's been told, you're pregnant, you really shouldn't take your migraine medication, but she wants to come in and see what her options are. Okay, that visit is because of her migraines. Now, her migraines might be complicated by her pregnancy, but it's not directly related to the pregnancy. And so, again, that is going to be a problem-oriented visit. Okay? Now, the delivery services include admission to the hospital, the admission history and physical exam, management of uncomplicated labor and vaginal delivery with or without episiotomy, with or without forceps, or cesarean delivery. So this is when we need to keep the ICD-10 and the CPT guidelines completely separate. Under CPT, it tells us that a vaginal delivery can include an episiotomy and use of forceps. Now, the one thing it doesn't say is they don't usually use forceps that often anymore. They use what we call vacuum suction, and that's also included in this, forceps vacuum suction. Okay, however, if we use forceps or vacuum suction, on the diagnosis side, that no longer is an 080, a normal delivery. Remember, on the ICD-10 side, 080, which is normal delivery, is when mom is at full term with a healthy baby, mom is healthy, nothing goes wrong, single, live born, vaginal delivery, only episiotomy included. No forceps, no vacuum. So be careful on both sides, okay? CPT, we can use forceps or vacuum. ICD, for that normal delivery, we cannot. We have other codes to describe vacuum suction and things like that, okay? Now, for these cases where mom is out of area or something else happens, when reporting delivery-only services, report inpatient post-delivery management and discharge services using evaluation and management service codes. Delivery and postpartum services include delivery services and all inpatient and outpatient postpartum services. So again, we're going to look at these globals that include the antepartum, labor and delivery and postpartum, and then things like delivery only. The other thing is, what if you have multiples? We're going to talk about what happens with twins and triplets. Now, it goes on to tell us medical complications of pregnancy, which include things like cardiac problems, neurological problems, diabetes, hypertension, toxemia, hyperemesis, preterm labor, premature rupture of membranes, and trauma, and medical problems complicating labor and delivery management may require additional resources and may be reported separately, and of course also may be billed separately. Okay? So it goes on to tell us, though, for postpartum care only services, 59430, this includes office or other outpatient visits following vaginal or cesarean section delivery. So for instance, again, mom could be visiting someone out of area, out of state, and she goes into labor. We still have codes for those, even if she's not being seen by her normal OBGYN. We also have labor and delivery and postpartum care separate, also for patients that need to be switched over from what we consider kind of the traditional OBGYN to a specialty OBGYN, depending on what the issue might be. Now, this is important. If all or part of the antepartum and or postpartum patient care is provided except delivery due to termination of pregnancy by abortion or referral to another physician or other qualified healthcare professional for delivery, see the antepartum and postpartum care codes. So again, ultrasounds, we can do amazing things with ultrasounds. We have our different modes. We also have a 3D and a 4D mode. for obstetrical ultrasounds. And the 3D and 4D modes can be used if they see something abnormal on a regular maternity ultrasound. And so, for instance, if they notice that perhaps there's part of a limb missing, they can then go and do a 3D ultrasound to see what they can find out about that limb. Or if they see something with the brain or something missing inside the body, the baby's missing their kidneys, they're missing part of their brain, they're missing anything that you can imagine that we can see on an ultrasound. You know, those are the times where we might have to get a specialist to come in and assist with labor and delivery. So again, circumstances, you know, can always be different and things can change based on what happens once mom actually gets to the hospital for labor and delivery. So the first thing that we're going to see is the antepartum and fetal invasive services. So these are going to include things like our amniocenteses. Now, just keep in mind, the amniocenteses, the surgical puncture to remove fluid from the amniotic sac, is no longer done past 3 months unless for some reason there's a very specific test that we need to do. And it's because after the first trimester, it is dangerous to do that procedure because something could go wrong. So that's why if you find out you're pregnant, after 12 weeks, after your first trimester, they do not do the amniocentesis for testing. They go and they take mom's blood because now we can separate in the lab mom's blood from baby's blood and we can test both at the same time. This is where we're also going to find things like that non-stress test I was talking about, 59025, which is basically just a belt. And in the center, I mean, there's a couple different looks of the device, but it tends to be more of a round disc that sits on top, and we're looking for the heart rate and making sure that the baby's heart rate is good and strong. Now, this is a great picture right here, vaginal delivery. And this is important, especially on the diagnosis side. Remember, the proper way a baby should be coming out of the birth canal is head down, face down, just like this picture. Okay, and the reason is because the top of their head can come out first, and they're not hurting their neck. Usually, it doesn't break any of the bones. However, babies that start coming out sideways or come out face up, those are babies that can have issues with their neck. They have more issues with the cord. They also can break their clavicles, the bones that connect our sternum to our shoulders, because again, the birth canal is made for the baby to move ever so slightly, but really head down, face down is the way they're supposed to come out. So that's what we want. So code 59400 is our, as you can see, I wrote there, global routine obstetric care, which includes antepartum care, vaginal delivery, again, with or without episiotomy and or forceps, and postpartum care. So this is the whole shebang, okay? However, any visits above and beyond what the guidelines tell us, we can code separately, so keep that in mind, okay? But what happens if mom has a vaginal birth of twins? Aha! Well, that's why we have these codes. So, see how we have 59409, okay? So, this is vaginal delivery only. We can use this code for a specialist just coming in to help birth the baby or for a multiple. So what we would do is, if mom is using the same OBGYN or the same practice, what we would do is for baby 1, 59400. For baby 2, 59409. Why? Because again, they're birthing a second baby, but they're not doing all of the care separately. So it's just the delivery that's separate. But we also can include postpartum care as well. Again, sometimes people move, you know, maybe a woman has to move when she's 8 months pregnant. And so she's been followed by her OBGYN where she used to live. And now she ends up doing labor, delivery, and postpartum with another OBGYN. We also have like 59412 external cephalic version with or without tacholysis. So this is when the baby's in the wrong position. They are not head down, face down. A lot of babies for some reason like to go sideways. So their head and feet are on the left and right side of mom's body. And again, what the doctor does is put pressure and pushes on different parts so that they are able to make sure that they can get the baby to come out. We also have the delivery of the placenta, which again can happen. If there is a problem with mom, the placenta might not come out right away. If mom is doing cesarean delivery, 59510, again is global, one baby. And if mom is having, let's say, twins, we do 59510 and 59514, one for baby A, one for baby B. But you'll notice we have another one of these little add-on codes, 59525, subtotal or total hysterectomy after cesarean delivery. And again, this is when we're removing the uterus after cesarean delivery. Again, some women already know ahead of time that they need this procedure done for a variety of different reasons. And so again, we have to be careful because this is an add-on code to the primary procedure. And again, we can use 59525 with 59510, 14, 15, 18, 20, and 22. Now, I know some of you might be wondering, well, what happens if mom vaginally delivers one twin and then she cesarean delivers the other? Ha-ha. Okay. So, in that case, we would do the routine obstetrics care for vaginal delivery, and then we would also use code 59514. And sometimes that happens. So baby A comes out, no problem. Baby B doesn't want to do it. Could be in the wrong position. There could be a complication. There could be an issue with one of the placentas, one of the cords. So again, we can mix and match. But in general, just keep in mind, vaginal is always going to come before cesarean. So we wouldn't take one twin out by cesarean and the other one by vaginal. We would always do vaginal first, then cesarean, because that's the way it would actually happen. Okay, so keep that in mind. Again, we can have different scenarios when it comes to multiples. So some babies do it, some babies do. Now, we have something called VBAC, which is vaginal birth after cesarean. So they tell us patients who have had previous cesarean delivery and now present with the expectation of vaginal delivery are coded using codes 59610 to 59622. If the patient has had successful vaginal delivery after a previous cesarean delivery, or VBAC, use codes 59610 to 59614. Okay, so usually most OBGYNs and doctors will agree they want women to wait at least 2 to 3 years in between a cesarean section and a vaginal delivery. And that's because of scar tissue. They don't want anything to pop open in the multiple layers. They don't want anything to rip while mom is pushing. So here's the thing. Sometimes it's very successful. Other times a woman has had a cesarean. She comes in, she tries to vaginally birth, but then she has to have another cesarean. That's the next set. If the attempt is unsuccessful and another cesarean delivery is carried out, use codes 59618 to 59622. Okay? To report elective cesarean deliveries, use codes 59510, 514, or 515. And that is something that women do. Some women will choose to get a cesarean done, perhaps because they've already had a cesarean done. So 59610 is the global for vaginal delivery after previous cesarean delivery, okay? And 59618 is attempted vaginal delivery after previous cesarean and them having another cesarean delivery. And again, we also have codes for just the delivery and the delivery with postpartum care. So we want to keep that in mind. Now, the last set of codes here are our abortion codes. They are in this section. And so, again, for this, we need to know how are they performing this procedure. Okay, and so we need to know, are we doing it surgically? Are we doing a D&C, dilation and curettage? Are we doing a D&E, dilation and evacuation? Specifically, what are we doing for this? And so again, when it comes to these procedures, we need to know from the doctor what was the technique that they used so that we can make sure that we grab the correct procedure code. All right, guys. Female genital And maternity care is not difficult. But again, it's the terminology that you need to make sure and the specifics about the situation, especially when dealing with maternity care and delivery. Good luck.